Ok. Ok, Susana, só uma palavra em português para agradecer, mas vamos switch to English, ok? It's really my pleasure to welcome and to thank very much Susana Vasneri for joining us today in this seminar. I would like to say that Susana, she's a professor and a research group leader at the Kirby Institute in Australia, and she has a rich and well-known work in the area of traditionally so-called tropical diseases. She worked in Angola, in Timor. Now she's based in Sydney, and the point is, and it's probably one of the most interesting things, is that she has a very interesting and rich life course in the area of science, because she was trained as a basic scientist, and she got close to the population health sciences, and she's doing research and teaching in one of the most relevant areas, especially for low-income populations, even among countries that are not that poor. So it will be a pleasure for us to listen to Susana, giving us her knowledge and thoughts on the strategies to optimize the control and hopefully the elimination of so-called neglected tropical diseases. So, Susana, thank you very much. You have listening to you a large group of public health doctors in training and people in their master or PhD studies. So the screen, it's not exactly the floor, but screen is yours, and thank you very much for giving us the pleasure to have you this afternoon. Thank you.
Thanks, Enrique, and thank you everybody for being present wherever you are and listening to me. It's really a pleasure. It's kind of almost a tradition or when I come to Portugal to visit family and friends to sometimes it happens to give a talk, and it's always really interesting for me, as I studied in Porto. I'm from Porto originally, and so it's really a great pleasure for me to have this being part of my visits. I'm sorry that we cannot do these face-to-face this time, but hopefully next time I'll get to meet you in person, or some of you. Anyway, so I'll switch to science, and we'll try to operate this magic here with Zoom. Shouldn't be a problem, given that we've been doing this for a couple of years, unfortunately. I'll just move this so I can switch to slideshow. And yeah, okay, so I think it's okay now. Yeah, please feel free to interrupt, but otherwise I'll also take questions at the end, hopefully. I think there will be time. So I want to start by saying that I am presenting the work of my team. Either we're both current team members, postdocs, former postdocs and current students. And I'd also like to acknowledge Professor John Calder, who is the Global Health Program lead at the Kirby Institute, which is a research institute part of the University of New South Wales, where I lead the NTD research group, as Efik just said. I would also like to say that none of this work could be possible, especially now in any time. But I think that the importance of really strong collaborations is really important now that we are doing a lot of these things remotely. But yes, so this work wouldn't be possible without strong in-country collaborations, and I'll mention some of our collaborators as I go along and mention the individual studies. So I'm sure this is probably familiar to most of you. Neglected tropical diseases, I'll be calling them NTDs for short, for the sake of time, are a large group of infectious diseases that are caused by protozoa, virus, bacteria, and parasites, and they affect globally more than 1 billion people all over the world, particularly poorest populations. They impair physical and cognitive development in children and then lead to limited productivity in adults, therefore perpetuating the poverty cycle. Their name, the neglected part of it, also reflects the fact that historically they have received little funding and attention. I will be mentioning the diseases in bold, which are the main focus of my current research. And in common, these diseases or infections I'll be mentioning have in common the fact that one of the main public health strategies for their control or elimination is preventive chemotherapy, which is also called MDA, short for mass drug administration, if it's given to entire communities. But basically PC, so preventive chemotherapy, consists of regular periodic administration of medications to groups at risk without prior diagnosis. And this has to be repeated annually or biannually, and with the aim of controlling morbidity and in some cases actually eliminating transmission. So starting with the most common NTD, soil-transmitted helminths, intestinal parasites, or STH in short. They are a group of 5, actually 6 species. I only have 5 here. The 6th one is less common and less kind of subject to these control strategies until now. But basically, they are transmitted through the injection of contaminated of feces containing eggs or skin penetration. Their infection or chronic infection with this STH lead to growth delays and anemia. And as I mentioned, so one of the main control strategy is preventive chemotherapy targeting school-age children with the aim of eliminating morbidity. I'll also be talking about scabies, which is a skin NTD, and it's caused by this mite. It leads to itching and rashes, and may also cause secondary bacterial skin infections or impetigo. Recent trials led by Lucia Romani, who is now a postdoc in my group, showed that MDA, so mass drug administration with ivermectin, is actually more effective than the standard treatment, which is the delivery of topical permethrin to infected individuals and their contacts. So now MDA for scabies is hopefully going to start being rolled out as in countries, or it is at the moment, actually. I'll mention some of those initiatives later on. I'll also mention Shisosomyosis that is caused mainly by one of these 3 different parasite species of Schistosoma. It's transmitted through skin penetration and includes a snail host, and it leads to malnutrition and anemia, among other sometimes more severe morbidity. Again, control strategies through preventive chemotherapy, mainly focusing again on children with praziquantel, and with the aim of elimination as a public health problem. which means eliminating morbidity mainly. I'll also talk about trachoma, which is caused by a bacteria, chlamydia trachomitis. It's transmitted through flies, and infection leads or may lead to blindness. One of the main control strategies is MDA, so entire populations are giving the antibiotic azithromycin. I'll be also mentioning Yaws, another skin NTD that is caused by the bacteria Treponema perteniu, that is very similar to the bacteria that causes syphilis. And it leads to chronic disfigurement, and it's actually targeted. It's the only NTD, I believe, that is targeted for eradication, so global elimination, and that should be reached by MDA with azithromycin. So Yaws is restricted to a smaller number of countries, and prevalence is usually quite low, and in many cases we are close to elimination. I'll just mention a few studies that were kind of initiated because of this other NTD, lymphatic filariasis, which is another parasitic NTD transmitted by mosquitoes. It causes abnormal enlargement of body parts, so it's also called elephantiasis, leading to pain and disability, and its control strategies through MDA. So entire communities being treated with a combination of albendazole and usually DEC or diethyl carbamazine citrate, or sometimes ivermectin, or sometimes in addition also includes ivermectin. So it can be a 3-drug regimen. Okay, so moving on to the research that I'll be talking about. So these are the diseases I talked about. So control strategies, I'll be mainly presenting studies that are focused on preventive chemotherapy. And I'll be mainly presenting results from intervention trials or cross-sectional surveys that have to do with monitoring and evaluation of NTD control programs. We also do research that tries to optimize diagnostic techniques. I'll talk a lot, results provided by real-time quantitative PCR for STH, which is not quite the standard. And we are also conducting some social science research, like health systems feasibility and community acceptability of these programs, as well as health economics and mathematical modeling, but this is ongoing, and I will just mention that we are doing them. This is just a layout of the talk pretty much. So basically, I'll present our research across 3 main themes. One is optimizing strategies for the sustainable control of soil-transmitted helminths, or STH, and I'll be talking about studies in Vietnam and Solomon Islands. Then I'll talk about intervention studies on integrated control of NTDs, so assessing the impact of existing drug combinations on multiple NTDs, and these will be studies in Timor and Fiji. And finally, I'll describe several examples of our support to the Ministry of Health in endemic countries to assess the impact of their NTD control programs on multiple NTDs, Trachoma, STH, and Schisto, and multiple NTDs in Vanuatu. Okay, I'll start then with the code STH, or that stands for Community Deworming Against STH. And this is a large RCT, randomized controlled trial for STH control. This work, as you can see, involves a large group of people, but I should mention the former postdoc who worked with me in kind of starting this, Naomi Clark, as well as Claire Dyer, who is now a postdoc in my group, and Dean Nguyen, who is an academic at Thanh Nguyen University in Vietnam, and who is the project coordinator and led all the field work. This is funded by the Australian National Medical Health Research Council. So why this trial? So as I think I mentioned, STH control relies mainly on school-based deworming, so targeting school-age children because they are believed to be the most that group and group suffering the highest morbidity. However, mathematical modeling and a pilot that I led suggests that community-wide, so mass deworming, will have greater impact on transmission, not surprisingly, leading potentially to fewer reinfections in school-age children. And that's basically the hypothesis that we wanted to test, that community deworming will lead to fewer infections in children when compared to school-based targeted deworming. And so I led a trial in schools, in primary schools in 13 districts of Dak Lak province, which is here in Central Highlands of Vietnam. A brief layout of the trial. Basically, we had an intervention arm where we had 32 schools and surrounding communities where both children at school and entire population in those surrounding communities received the deworming medication albendazole. Then we had a control arm where 32 schools were selected, and only these school-age children attending these 32 schools received albendazole. And we measured infection in school-age children at baseline and at follow-up 12 months after the albendazole distribution, and this was done by quantitative PCR. And we are now currently finalizing data analysis. This was quite a large undertaking. I think the largest trial I've been involved in so far, or led so far, in collaboration, as I said, with Dai Nguyen University and the Ministry of Health and Ministry of Education in Dak Lak. Dean did a brilliant job kind of leading this on the ground. We had 13 teams with 4 people each led by Dean, plus supervisors and lab technicians in country, to a total of around 60 core staff. And they were supported by almost 300 village and hamlets, so community health workers in the hamlets where we worked. We visited more than 100 villages and gave medications to almost 90,000 people, and also gave tablets to more than 20,000 children at school. And we collected around 9,000 stool samples from children at each time point that, as I said, were diagnosed by PCR at the University of Melbourne in Rebecca Traub's lab. I just want to mention first a quick risk factor analysis conducted by Angus Hughes, who is a master's student in my group. And we found that basically kind of using the questionnaires that with which we interviewed students and their carers, and we found that factors like belonging to an ethnic minority or defecating on the ground increased the risk of infection at baseline, as you can see here, sometimes quite dramatically. We are now conducting the impact assessment analysis, so to test the hypothesis that we led us to this trial. You can see here that disappointingly, there doesn't seem to be a difference between prevalence of Necator, which is the main STH prevalence in Vietnam, when comparing the two arms. Basically, there's a bit of an imbalance as well at baseline. There was between the control intervention arms, despite this being randomized, which is a shame. But nevertheless, there doesn't seem to be a significant difference in prevalence reduction between control and intervention arms at follow-up. So 12 months after giving albendazole, either to children only or entire communities. These measured in children. We do see a borderline significantly greater reduction in infection intensity in the intervention arm compared to the control arm. So if we look at the proportion of infections that are high or moderate intensity, you hopefully will agree that there's a higher proportion in the control arm than in intervention arm. And basically this was one of our primary outcomes, because as I mentioned, the aim of deworming is actually decreasing morbidity, and that morbidity for WHO is measured by looking at the proportion of these high and moderate intensity infections. As I said, we are currently conducting, so this was, I just presented the cluster analysis, and we are now also running models, GLMM models, so individual level models that allow us to take into account these demographic and socioeconomic variables, so in the other individual level variables that we also collected at baseline through those questionnaires that I mentioned. Nevertheless, they will not change the cluster level analysis. Maybe they'll make it a bit more nuanced, but that's it. We are also collaborating with Luc Feng from Erasmus Medical Center in the Netherlands, who is a mathematical modeler, so that we can use this data that we collected, or he can use our data to predict the long-term impact of targeted and mass deworming on STH transmission. So basically, I've, as I said, this trial only involved one round of deworming and measuring infection 12 months after, because obviously there's limited funds that we can access, but it is possible that if we repeated the community deworming over a longer period of time, that we would start seeing an effect in children after multiple rounds. I don't know if I mentioned that, these preventive chemotherapy programs for STH and other NTDs, they last for, they can last for decades. So it's not, also it's disappointing, but not necessarily surprising that we don't see an effect after 1 year. I also have Paul and Phoebe, 2 PhD students working on this trial. Basically, Paul is looking at the health economics, so comparing cost effectiveness of the two approaches, and Phoebe is looking at acceptability and feasibility of these two approaches for STH control. Okay, now we'll switch to the Solomon Islands and the work of Brendan Lee, who is a PhD in the group, and this project is to assess the impact that ivermectin MDA on scabies has on STH. So I'll explain a bit better, hopefully. So basically, we are doing this work in collaboration with this large group of people, and the RISE, as it's called, the RISE trial, standing for Regimens of Ivermectin for Scabies Elimination, is a trial that is led by MCRI, Murdoch Children's Research Institute in Melbourne, led by Professor Andrew Steer. And the aim of the trial is to assess the impact of 1 versus 2 doses of ivermectin MDA on scabies. I will not be talking about this aspect of the trial because it's not mine. But basically, I think I have mentioned that ivermectin is effective for scabies control as a public health intervention. But the original trials used 2 doses of ivermectin, which is a bit of a nuisance because most MDA programs rely just on 1 delivery per year, whereas the scabies trials used 2 doses of ivermectin 1 to 2 weeks apart. So that would mean if this is rolled out, by countries, it needs a second visit by the health staff to the villages, and that's quite, that's a bit problematic, and it doesn't align with the rest of the MDA programs. So these trials aims to test to see if 1 dose only is effective. Anyway, we are taking advantage that this trial is happening with these collaborators of ours, and so we added an STH outcome to the trial. And this is because ivermectin is effective or efficacious against some STH species. So we conducted cross-sectional surveys of these 18 communities where the trial is taking place in the western province of the Solomon Islands. And so around 1,000 samples were collected in 2019, and then 20 months after, a follow-up samples were collected. And we are now, or I'm now, sharing with you the results of the baseline data. So we don't have follow-up yet because the samples are being diagnosed by PCR. Anyway, I hope you'll see here that there's all the STHs are quite prevalent in the Solomon Islands, and in fact, more than half of the population is infected with at least one of the STH species. And he also conducted a similar risk factor analysis using those questionnaires. And we saw that, for instance, owning a household latrine leads to lower odds of infection. So, as I mentioned, we are now diagnosing the follow-up samples and hope to have the results early this year. I'd just like to mention that given that the Solomon Islands is one of the few countries actually that is rolling out ivermectin MDA for scabies control, our results may also shed some light on whether that program for scabies can also impact STH. Nevertheless, so we have already shared these results with the Ministry of Health and support their, I guess, goal of scaling up school deworming with albendazole to the entire country. So they only do this in Honiara, the capital, because of several reasons, but they want to expand to entire country, which would make sense because there's really a lot of STH there. I'll now turn to our second research theme, which is on the integrated control of NTDs, and go through a few studies that test the impact of existing drug combinations on multiple NTDs. This first study is a collaboration with Josh Francis at the Menzies University, at the Menzies School of Public Health, and this is also part of Brendan's PhD, and is done in collaboration with the Ministry of Health in Timor-Leste. I'll also like to acknowledge Salvador Amaral, who is our project manager in Timor-Leste. Salvador and I go back for a long time now, 2012, when I was living in Timor and conducting another trial on STH, and we've been collaborating since then. So in this study, we are assessing the impact of Timorese-led MDA, so basically the Ministry of Health of Timor in 2019. So Timor is endemic, or was endemic, for lymphatic filariasis, and they had been doing some MDA distribution, MDA programs for LF elimination with albendazole and DEC. And in 2019, they added ivermectin. So this was at the time a very new thing that WHO was supporting in some countries, because basically it kind of speeds up the elimination of LF as a public health problem if you add the ivermectin to the two drugs. So because of what I just said, that ivermectin and albendazole obviously also have an impact on STH and scabies. We wanted to assess the impact of that national program that focused on LF, on scabies and STH infections. So it was a small study in 6 schools across 3 municipalities in Timor, and we conducted before and after surveys and recruiting around 1,000 children in each time. For this one, we already have, we are finishing statistical analysis, but pretty much the results, I'll share them. So I hope you can see here that the prevalence of scabies with just one dose of ivermectin decreased from almost 40% to 13%, whereas the prevalence of impetigo decreased from 12 to 2%. So this is really great news regarding what I was saying, that the original scabies trials used 2 doses of ivermectin in the same MDA round. And here we are showing that with just 1 dose of ivermectin, we still get a significant decrease in scabies prevalence. Looking at STH, you'll see here that the prevalence of Ascaris, which was the most common in this area of Timor, around beginning with 18% in these 6 schools, didn't really decrease after, well, when we looked at these numbers after 18 months after the MDA. This is not surprising at all. So it's not for, there is a reason why MDA or preventive chemotherapy programs, as I said in the beginning, are regular administration of drugs. So you have to do this every year. And in the case of STH, there is a lot of evidence showing that after 6 months after you give drugs to people, prevalence levels start going up again just because of reinfection. So that's what this shows. It doesn't have, it doesn't have to do with drug efficacy or effectiveness of the intervention. It just has to do with reinfection. It is surprising that we can still detect a prevalence reduction of trichuris 18 months after baseline. And so trichuris is slightly different. So albendazole is not efficacious against trichuris. So usually it's really not that much changed when you do the normal STH control programs. And that's why I wanted to do these studies, because in terms of efficacy, it has been shown that adding ivermectin to albendazole is what will be able to control trichuris. Trichuris is just less common, so it has been receiving less attention. Anyway, it's quite interesting that we are seeing these with trichuris. It could be just because we started at a lower prevalence, or it could be just chance because we powered the study for the more prevalent STH, not for trichuris. That is less common. Okay, so in conclusion, as I said, I'm incorporating 1 dose of ivermectin into integrated NTD control programs can benefit scabies, impetigo, and trichuris. I didn't show that, so I showed that there was no impact on prevalence of Ascaris, but there was on intensity of infection. But kind of overall, this evidence hopefully will be used to support ivermectin donations specifically designated for scabies and STH. So ivermectin in terms of NTD, so all these MDA programs that I've been mentioning rely heavily on donations from pharmaceutical companies. So back in 2012, there was this thing called the London Declaration, where the WHO, several pharmaceutical companies and other kind of donors and global stakeholders committed to this roadmap for NTD control. And basically the companies committed to giving drugs for free to endemic countries for specific diseases and for specific age groups in some of the cases. So ivermectin historically has been used not for COVID, as I hope you know, but for onchocerciasis. And so there's donations for onchocerciasis eliminations, but there's no more ivermectin being given to countries for other diseases like scabies and STH, for instance. Okay, and again, these results also show that there's still enough STH in Timor that justifies further rounds of preventive chemotherapy with albendazole, and ideally with ivermectin. I will now mention 2 studies that are being led not by me, but by Professor Andrew Steer at MCRI. And I'm mentioning them because they have had the long-term contribution of Lucia Romani, who is a senior research fellow in my group. And one is this one big shift in Fiji. And again, kind of is similar to what I've described in Timor. Basically, the Ministry of Health conducted a national LF campaign with, again, ivermectin, DC, and albendazole. And again, this study which was a large-scale study with more than 100,000 people, aimed to determine the impact of that ivermectin that was used in the LF campaign, had an impact on scabies and impetigo, but more than that, if it had an impact on hospitalizations and access to care for bacterial infections. So this was conducted in the northern division of Fiji. These are the results, I guess, for scabies and impetigo. Now, the beginning, so for scabies overall, the starting prevalence wasn't that high, and there wasn't really a significant impact detected by this study in overall scabies, but there was an impact on moderate and severe scabies. So there was a reduction in severe scabies and also in impetigo, which is good, positive. But there was also a detectable decrease in hospitalizations with skin and soft tissue infections. And that's really quite exciting, because this shows the additional benefits of ivermectin MDA that can be tracked down to hospital and health center level. Lucia is also part of the FIT trial, or Fiji Integrated Therapy. So again, it's a trial conducted in Fiji and also led by Andrew. And this is a 3-arm RCT that was part of the original trials that were aiming to test the effectiveness of this 3-drug therapy for LF, and that was funded by the Gates Foundation. And again, as I mentioned before, so basically the trial was around LF, but then this component was to look at scabies as well. This was, as I mentioned, I think a 3-arm RCT. Basically, one arm was the regular 2-dose MDA for scabies, compared to only 1 dose compared to standard treatment, which is what I've mentioned, permethrin for infected cases and contacts only. And this was a non-inferiority trial. So I hope you'll see here. So this is baseline, blue and orange, 12 months. That you can see that there was a significant reduction in scabies prevalence in all treatment groups. And again, this study suggests, like the Timur study I showed, that 1 dose ivermectin is effective against scabies, which from the perspective of MDA programs is quite good as a result, because it allows ivermectin to just be delivered 1 time per year instead of having to do it twice in 2 weeks. Okay, so finally, not really finally, because I still have quite a bit to go through, if you're okay with that. I would like to provide some examples of our work supporting the Ministry of Health of endemic countries to assess the impact of their NTD control programs on different NTDs. And these include surveys to inform whether there is in fact a need to conduct MDA or to roll out an MDA program. And that this is exactly what I'm talking about. So this is Nauru, or study Nauru, and I'd like to acknowledge Sue Chen Badinue, who is a public health nurse and the lead of the Trachoma program in Nauru. And this study has been funded by the Fred Hollows Foundation. So I should probably, and again, as usual, it involves a large group of people from different institutions. I should probably mention that the epidemiology of trachoma in the Pacific is different from African settings, and this is now called the Pacific Enigma. And this means basically that there is a high prevalence of clinical signs of trachoma. So usually in the field, trachoma is diagnosed like this. So you look at trachomatous inflammation follicular, or TF, and that's how you decide whether there's a need for MDA or not, usually. So there is TF in the Pacific, but there isn't trichuris. There isn't, yes, trichuris. So trichuris is kind of, sorry, there isn't trichiasis, which is the late stages of trachoma infection. That is the scarring that caused by constant infections, and that kind of it's the precursor of blindness. And also in some settings where this has been done because of this kind of contradiction of TF but no trichiasis, people in a few countries have started collecting swabs to look at presence of bacteria by PCR, and in some Pacific countries there's not that much. So because of this specific enigma or this contradiction between presentation of TF but no infection, we performed additional sample collection. So at the same time that the Ministry of Health was leading this trachoma survey of all ages in all clusters of Nauru, doing clinical examination, looking for TF, we also asked children only for an eye swab and a blood spot to look at presence of infection and also seroprevalence of anti-PGP3 antibodies, so basically a sign of previous exposure to chlamydia. So we did this nationally, which is not a very big task in Nauru. Nauru only has 11,000 inhabitants, and we examined, or the Ministry of Health examined more than 2,000 people, and we examined almost one children. Okay, so the results are here for those around 800 children. Prevalence of TF was, so clinical presence of trachoma, or signs of trachoma, 22%, with a presence of bacteria by PCR of over 34%, and also antibodies at similar levels. You can see here that both clinical presentation in blue and antibodies in pink increase with age, whereas the green is PCR, so bacteria is more or less constant. So in short, these results indicate that there's a high levels of transmission, of trachoma transmission among children, and that presents a risk of ocular damage. And because of these, the Ministry of Health did implement a round of azithromycin MDA in 2020. I also want to mention this additional survey we conducted that Lucia is now analyzing the data. So you will probably be familiar that azithromycin is also used for sexual transmitted infections, for instance, chlamydia and gonorrhea. And so we also conducted a cross-sectional survey just before this azithromycin MDA, and then 9 months after, I believe, to see if there was any additional impact on STIs in young adults in Nauru. And so we collected urine samples that were analyzed by PCR. These is just results for just showing chlamydia here, and you'll see that there was a significant relative risk reduction in comparing 9 months and before MDA, and after MDA compared to before MDA. So these is just kind of additional evidence suggesting that NTD MDA programs may have also benefits outside NTDs. They may also have problems, and I know the antibiotic resistance people are. This is a concern, obviously, that we can discuss later on. But nevertheless, azithromycin has been given as MDA for trachoma for a very, very long time, actually. Okay, so another example of this sort of study is another trachoma example in the Solomon Islands now, also funded by the Fred Hollows Foundation. And this is work led in the field by Oliver Sukana, who is the NTD unit lead in the Solomons. So in Schweizl, there was a need of conducting this survey for a different reason. So in Nauru, it was to decide whether an MDA should be initiated, and in Solomons was to decide whether what was going on. Basically, Solomons has been doing azithromycin MDA for trachoma for a while, and basically the idea is to do a couple of rounds and then assess prevalence. If prevalence is under 5%, that means that it has been eliminated as a public health problem. And then the countries stop MDA, and then they do surveys to make sure it doesn't go up again. And then they submit an elimination or as a public health problem dossier to WHO, so they are certified. So they were doing this, but then they conducted a survey in 2019, and it was very surprising to see that prevalence of trachoma, of clinical trachoma in this province had risen to 11%. So people are still not quite sure what was going on, but basically the first step that we got then involved was to confirm if this clinical presentation did in fact correspond to trachoma or if it was something else. So again, we recruited children in 15 villages across Schweizl, so the villages that had a high prevalence in the 2019 survey and some additional ones. And besides the clinical examination for TF, we also collected a swab and the blood spot. And these are the results here. Maybe just focus here. You can see clinical TF 18%, and that in this case, PCR confirmed presence of bacteria only in 8% of children, so very different from the Nauru case that I described. But there was a comparable prevalence of antibodies, so suggesting that in fact these children had been exposed, which is true because as I said, there had been MDAs before, because there was indeed trachoma before. But there is something more besides trachoma causing this clinical presentation. But nevertheless, this 8% or 8.5 is above the WHO threshold for MDA. So this means that Schweizl needs to engage again in azithromycin MDA. Finally, for trachoma, I'd like just to briefly mention the work that the Kirby Institute, in particular, John Calder and Kylie Cowling, have been doing or leading with in the National Trachoma Surveillance and Reporting Unit that I'm also a part of now, but this has started a long time ago, prior me joining the Kirby. So this unit was established in 2006 by the Department of Health of Australia. So basically, Australia is actually the only high-income country that is endemic for trachoma, and that happens only, it's very restricted, it only happens in some of the jurisdictions and only in jurisdictions, Aboriginal communities, basically. And so this unit, what we do is that we analyze the data that is collected by the Department of Health, and then we produce annual reports and manage kind of the submission of the elimination dossier once we get the targets. And basically the strategies that are being implemented by the different jurisdictions in Australia are similar to the rest of the world, with some nuances, but pretty much azithromycin distribution. And also some work has been done or attempts to improve environment, so housing and hygiene, so that transmission can actually be properly affected. So you can see here that from the beginning of this program, so 2006, there's been a decrease of trachoma prevalence in all the jurisdictions, and overall, this is national. We are now reaching the 5% threshold, which is good. But you'll see here that there's still some communities in two of the jurisdictions that have quite high, so above 10 or 20% prevalence of trachoma. These are all very small communities, like hundreds of people, maybe, you know, a couple of dozens of children, sometimes even less than 5 children. So like the numbers can fluctuate quite a lot. So it's very different from, obviously, from the other kind of lower income country settings, but nevertheless, it's there. Okay, switching to continents and actually also switching a bit, diseases, but it's a final example of our support to the Ministry of Health in countries where there's NTD control programs. So this, as I mentioned, Angola. So I'd like to acknowledge Adam, who's a postdoc in my group, and Sergio. So this work has been, Sergio Lopes. So this work has been a collaboration with the Mentor Initiative and the Ministry of Health of Angola. So Sergio is one of the main mentor collaborator on the ground. I'll also acknowledge Marta Palmeirim from the Swiss TPH, who was the parasitologist who supported this study as well in terms of microscopy on the ground. And this is funded by the END Fund. So Shisosomyosis and STH infections have been recognized as public health problems in Angola. Mentor and the Ministry of Health have conducted a baseline prevalence survey in these provinces back in 2014, and then this kind of led to the beginning or the more regular preventive chemotherapy program there. And so our role now was to support Mentor and the Ministry of Health to design and analyze and in some extent support the implementation of these impact assessments that were conducted mid last year. So we conducted parasitological surveys using RDTs for schisto, for both Mansonia and hematobium, so intestinal and urinary schistosomiosis, and then also microscopy for STH, but we can also look at schisto and using the same diagnostic techniques, and also in a subset of samples, molecular, so qPCR for STH. This was, again, a very large study, so more than 18,000 kids were recruited for the RDTs and almost 7,000 for microscopy. Just the results are a bit, disappointing, and also mainly disappointing for the Ministry of Health in Angola, with whom we have already shared these results, but basically there doesn't seem to be an impact of schisto. There's still quite a high prevalence of schisto after several rounds of praziquantel distribution, and this could be school attendance or poor coverage of their PC programs. And the same for STH. They're still above around 30% of kids at schools infected with at least one of the STH, and again, really not significant reduction at all. So there's the, I guess, ongoing need to keep doing more of the same, or I shouldn't say this, probably not the need to do more of the same, but probably need to modify the same to make it better, to see if there's a bigger impact. We're still analyzing the data in terms of intensity of infection, but in terms of prevalence, it's a bit disappointing. I would like to mention, I think this is the last project itself. So we just started being part of this initiative called the Pacific Integrated NTD Elimination Project, or PINE project. So this is led by Bridges to Development, which is an American NGO being funded by the Japanese pharmaceutical Takeda, and with the WHO and the Ministry of Health of Vanuatu and Papua New Guinea. They have funds from Takeda to support the Ministry of Health of these two countries I mentioned to implement 2 rounds of MDA to control or eliminate multiple NTDs in these settings. So this is the work that the Ministry of Health will be doing, and as at the Kirby or my group will be looking at kind of the impact assessment. So we'll be leading the surveys to assess the impact that these programs will have in multiple NTDs. So in the case of Vanuatu, we're looking at STH, scabies, and yaws, and we are doing parasitological surveys plus clinical examinations and serosurveillance as appropriate depending on the disease. I should mention Facia Taleo, who is the WHO officer in Vanuatu and is running the show on the ground. So we actually just finished this province the end of last year. So we are conducting surveys in 33 villages. So in total, we'll have around 10,000 participants that we hope can provide information on how successful this MDA program will be. And this is the last really, but it's just kind of a new program that I'm starting. So I was awarded, so I'm leading a partnership grant that just started in late last year. Basically, it builds on this idea that I've mentioned. So the fact that we know that in Vanuatu and West New Britain and PNG, as I mentioned, because of pine, but also in Solomon Islands, because of the World Scabies program, there are initiatives supporting the Ministry of Health of these settings to scale up the implementation of MDA programs. And so the research component builds on those MDA programs, and we have then specific research aims around improving diagnostic techniques to facilitate integrated surveys, and then also conducting secondary analysis, so using geostatistical modeling to better identify areas at risk, and also health systems feasibility and community acceptability of these strategies, as well as health economics related to that. And I think that's it. Thank you very much for your attention, and happy to take any questions.
Thank you very much, Susan. It's really fascinating, and it's a huge amount of work. I don't know how we'll proceed. Usually there is a sort of a screen where you have the questions, but you can just oh,
sorry, should I be looking for that?
Sorry?
Should I be looking for that, or can somebody?
No. Usually Andre is taking care of that, so she will handle it. But I think people can just make the questions using the Zoom. Just raise your hand, whatever you want to do.
Yes, if I have questions in the other side for the YouTuber, for those that are watching using YouTube, I can say, and we can go there.
I have a question. I don't know if I can put it. I'm Anna. I'm a student of the second year of public health course in Porto, and I would like to know a little bit more how was the path of Susana since her graduation until she got to the position that she has today. Thank you.
I don't know how many hours you have. No, I'm joking. Okay. But I'm happy to, I'm happy for Enrique, for instance, Enrique to share my contacts, if anybody wants more detail. But basically, I mean, I've multiple interests, and my career started with neurobiology, and I still think that's the most fascinating research topic, actually, the brain and how it works. But I realized I wanted to do something that has at least the potential to have more direct impact on and help also society in general. Basically, I'm concerned about equity, and because I'm interested from a scientific interest in biology and human health and the human health, and So I thought that public health of neglected tropical diseases was basically a good way of me to bridging my social interest in terms of inequities and my intellectual needs in terms of conducting research and finding new things or contributing to optimizing new things or current strategies. And then I also, I like traveling, I like to experience different cultures. So basically, I don't think there could be anything else I could be doing at the moment. If I could be allowed to travel again, I would appreciate it so I can go back to the field. But yeah, I think in terms of how I got here, looking back, I mean, I shouldn't be talking about that because that would take very long. But basically, I think it's from looking at what I did, basically, I guess I can say that it's really quite important, I think, to have lived in different settings, in Angola. So I lived in Angola 4 years, Mozambique 2 years, Timor almost 3 years, Kenya, Tanzania, Gambia, several months. So I think it's really important to be able to connect to people and actually understand and not just do research from the bench or from the office and have that distance, because your experience, I mean, my experience, even I'm still privileged, and obviously I've experienced these settings as an outsider that doesn't have to endure those, their lives, but I think I have a better perception of the problems and also of the systems and of the Ministry of Health, how it works and the limitations and the challenges and the interests and their priorities, because, ultimately we're talking about, countries that have their strategies and their priorities, and they should be them making the decisions. So, sorry, I don't know if I answered the question, but feel free to contact me for more. So so basically, I think it's important to live there. It's important to have some experience as an implementer in terms of delivering control programs. And obviously, if you want to do research, it's also important to have the technical skills on how to do research as well. So yeah, it takes some time.
There was a comment from Nisa in the chat, Susanna, asking you how do you see the
One Health
methodologies and as part of your
okay, so Rebecca Trop, so the person who leads the lab where I'm conducting the PCR for STH diagnostics, she's a veterinarian, and so we work together. You're right. I mean, a lot of these, not all, but for STH, for instance, I mean, some of the STHs are zoonotic, like one of the hookworms and strongyloides potentially, and obviously everything you do, if you just focus, so it is important at least to know the extent to which there are zoonotic STHs, actually, WHO still doesn't quite consider STH or some of the STHs as zoonotic, so that's a challenge to kind of, but they are, but maybe not in the kind of globally, but at least in Asia and the Pacific, there's quite a high prevalence of zoonotic STH. So, I mean, I think it's quite important to be aware of that and take that on board. I mean, I guess I'm using STH as an example, but like, as you know, I don't know if João works on STH or others who knows this, but like the same strategies that we use now for human STH control in terms of MDA programs have been used in cattle for even longer, so for several decades, and there's issues that already affect animals in terms of emergence of resistance that we should also be looking at. But obviously, if there is zoonotic transmission, we cannot just give drugs to people. We need to make sure that animals are also being treated. And then in terms of hygiene or kind of behavioral change programs, that's something that should also be incorporated, is like how you deal with animals. so yes, so it's something that I'm not necessarily kind of directly incorporating One Health approaches in my research at the moment, but definitely aware of it and in collaborating with others who do that. I think Daniela has her hand up.
Hi, good afternoon. First of all, congratulations for your work and for your presentation. I was just curious about your work on the impact of LFMDA on STH and scabies in Timor. And you mentioned that for A. lumbricoides, you don't see the differences, and that you believe that it was about reinfection. How could you demonstrate that it was how could you possibly study reinfections or demonstrate that it was caused by reinfections?
Okay, I mean, I could demonstrate, but okay, so basically, so there's two things. I mean, these, well, I guess, so, you know, what I'm doing in terms of public health strategies is really, I mean, some of it that I didn't talk about, it's like I was going to say that is not terribly novel in terms of the findings. I mean, basically, albendazole has been used for Ascaris lumbricoides control for a very long time, and the efficacy of albendazole on Ascaris is known to be very close to, you know, is more than 90%. So this means that in terms of efficacy, and I have done in some, like in the Vietnamese trial, because it's a trial, I did conduct an efficacy study to make sure that the drug was efficacious. But the efficacy just means, you know, you treat the people and the ones who are infected clear the infection. And to see that, you need to, you know, take a sample before you give the drug, you go back in 21 days and you take another sample. And if they clear the infection, you know, then they are infection-free, the drug is efficacious. And that's, but then if you go back one month or 6 months or a year later, like I did, and you look at infections, if people are infected again, that's because they were reinfected. So that's why I'm saying that is caused by reinfections, because I know that albendazole is efficacious. But because I didn't, you know, I waited more than a year to go back, what I'm seeing are new infections. And that makes sense because, you know, because of the transmission cycle, because eggs, Ascaris eggs, and all STH eggs, they survive in the environment for many months. Actually, in the case of Ascaris, I think can be up to 2 to 3 years. So even if you clear all humans that are in that community, just because you still have feces on the ground and, you know, you accidentally still eat, you know, whatever feces in a way, or ingest eggs, you will be infected again. And that's why the cycle continues, is because of there's a lot of eggs in the environment.
So you think that you needed to repeat the treatment?
Yeah, so the STH control programs, basically, they go on forever. I mean, that's the problem. And that's why I did that trial in Vietnam, is because, and that's why people from more the, you know, the research perspective, I mean, you do this every year to make sure that people have relatively low intensity infections, because those are the ones which cause morbidity. But so you don't have the goal of eliminating infection by giving these drugs to people. That will not happen, especially if you only treat children. So it's accepted as, you know, it's accepted by everybody that you just have to keep doing it. Yeah. Sorry, I'll just close it. Sorry, I look like I have a...
More questions or comments? Well, Sana, we don't want to take more of your time, but I think that there might be interesting to have your view on, namely, on the cycle of treatment infection, because some of these situations, they are very much related to the fact that there are no good sanitation systems. So they are mainly the result of poor public health structures more than other type of intervention. So did you ever try to, even when working with the ministries and so on, to try to have a kind of a integrated, more integrated,
yes.
More, yes, a more comprehensive approach to all this.
Yes. So yes, and I guess my first trial in Timor was actually on WASH, so on water, sanitation, and hygiene, and trying to assess the impact of WASH strategies. So basically improving access to water and access to sanitation on STH infections. And there are a lot of initiatives trying to bring that on as well. And I think that's going to be ultimately what will sort things out. And it's the same thing for trachoma. And I guess trachoma in Australia is even a more obvious example of that, because there is really no excuse that there's trachoma in Australia. And if there is because people in these communities live in very different housing conditions than I live in Sydney, right? And it's in the same country. The issue with WASH, and so, these are called diseases of poverty because they are diseases of poverty. It's the same thing. I mean, there were a lot of SCHs in the States and in Portugal and everywhere, really. And as we started using latrines, they kind of went away. So I totally agree. The problem with WASH is that it's much harder to do properly than giving pills to people. And so in the short term, the pills are very effective because they are very cheap. They just kind of delay a bit. I mean, they are useful because they are so effective and so cheap. WASH, every single country has an interest in improving WASH. It's just, even with the involvement of the Ministry of Health, it's just very hard to implement WASH programs in a consistent and sustainable way because it's much more expensive than the drugs. I mean, latrines, and there's different models of improving sanitation, subsidized models, community-led models where people have to do their own thing, and this is happening, but you cannot, it's very difficult to measure the immediate impact of these programs on disease levels or infection levels because they take longer, I guess. I mean, obviously there's benefits of improving conditions for, even for human rights reasons, but it's harder, I guess, to implement, but it's being done, and it depends. I mean, for STH, the evidence is quite mixed because of the longevity of the eggs in the environment. For trachoma, there's much more direct evidence, and actually, facial cleanliness is one of the strategies as well. I mean, but again, you need access to water, and access to water doesn't depend only on the Ministry of Health; depends on a lot of things. So yes, I mean, WASH is kind of underlying, and is also, I didn't mention this because I decided just to focus. It's in one of my first slides that I was going to focus on preventive chemotherapy programs, but WASH is the second strategy that is being pushed both by academics and by WHO. It's just a bit harder to implement.
Thanks, Susanna. I think there was a question by Niels that it can be the last. Do you want to phrase your question, Niels?
Hi. I was thinking about this, but I believe that with your question, Professor, it was a bit answered, because I was thinking about the fact that we have such high rates in these communities, much higher than in other countries, of course, developed countries. But maybe we could talk about the fact that we have other poor communities that don't face so much of these high rates of infection. I don't know if I was.
I mean, it depends on the disease that you're talking about. I mean, yes, I agree. Not because yours is quite focal. I mean, there's also a lot of environmental determinants for all of these as well, like ecological. I mean, so that also influences what diseases there are, and some of them are very clustered, like they are very focal, and some of them, like the STHs, are very widespread. And the STHs, I mean, other social determinants, as I mentioned, have to do with access to water and access to sanitation, mainly to sanitation, and then access to water because of hygiene behaviors. The same thing with trachoma. So yes, poverty is poverty in general, but then specific aspects of it in terms of access to water and sanitation influences your risk as well. And then there's, for the ones like trachoma, or for the ones that have and Shisosomyosis that relies on a host as well. It depends on ecological characteristics. You have to have the snail, so you have to have water. So it's not, it's focal as well. The same thing with the fly host for trachoma. So there's a combination of other factors, risk factors as well, that can then kind of differentiate and stratify, I guess, risk, which is why I was talking about the geostatistical modeling. So basically, with the geostatistical modeling, you can develop predictive risk maps, and you can incorporate in your models. So basically do these surveys, but then you add the layers of the environmental variables that are freely accessible in most places, temperature, water, land coverage, precipitation, altitude, and you basically, and then you can also, if you have other individual level information like, education or socioeconomic factors, you can also use that in your models, and basically then you do these Bayesian-based models that can predict in certain, and basically help you target where you're more likely to have higher prevalence of each one of these NTDs.
Thank you.
Thanks, Susanna. I think, well, if there is no other question, just let me thank you very much. And I hope we can meet at least next year. Yeah. If things don't change as we would love. So thank you very much for sharing with us all this knowledge, and I hope you have a nice trip back to Sydney. Bye-bye to you all.
Thank you very much. Thank you, everybody.